evening, everybody. It's a privilege to talk in front of such illustrious seniors and my colleagues. Thank you, Dr. Shah, for a very informative and illuminative speech. My job is much simpler, smaller, preventing depressive episodes in bipolar disorder, maintenance therapy. I will try to share what I have learned, and I have more questions than answers. I've learned from you. Maintenance treatment for bipolar disorder, what drugs we use, mood stabilizers, combinations of mood stabilizers and atypical antipsychotics, psychosocial therapies. We have to decide what are the most effective treatments and which treatment is likely to be effective for a particular individual. And we have to weigh the body of evidence, level 1, level 2, first line drugs, level 1 or level 2 evidence, second line, all this you must be knowing. And as Dr. Shah was saying, we usually go by the Canadian and ISBD guidelines. This looks very simple to me. And despite everything, we have very limited treatment options for bipolar disorder and management of depression. Lithium still has the strongest evidence. Other drugs like lamotrigine have been proved to be efficacious in some situations, especially in treatment of the depression in bipolar and in the manic, not in the manic phase, maintenance phase. First line monotherapy recommendation, lithium, lamotrigine. Second line, this slide has already been shown. Maintenance treatments, what have we? And it should be a long-term or a lifelong treatment. We have to debate about it. The guidelines are rapidly evolving and changing. You have to go by your clinical experience, benefit of the patient. And there is a substantial lack of clarity still which drug is most efficacious or what combination. And lithium still is a very effective molecule. High likelihood of relapse after discontinuation of effective lithium treatment. So if a patient is on lithium, just because someone is saying or for fancy, don't change it. Because after 5 months, there's 50% chance of relapse. A meta-analysis of placebo-controlled trials have shown that lithium reduces risk of manic relapse by 38% and depressive relapse by 28%. So lithium is a very useful drug. And maintenance treatment, monotherapy, first if you try lithium, what are the options? Lithium, divalproate, olanzapine, quetiapine for both depression and manic phase. Lamotrigine is another alternative, primarily for preventing depression. It's not so effective in the manic phase. Combination therapies, lithium, divalproate, quetiapine and lamotrigine, olanzapine, fluoxetine combination. Lithium should be retained if possible, even in low doses. Drugs which are not so effective, aripiprazole, ziprasidone, risperidone in the depressive phase, levetiracetam. And antidepressants, the recommendations are SSRIs other than paroxetine and bupropion could be used as first line treatment. Dr. Shah was telling about this. Avoid the use of tricyclics and venlafaxine, chance of manic switch or induction of rapid cycling. Antidepressants should not be used to treat a current mixed episode, and monotherapy is definitely not recommended now unless it was first treated as unipolar depression. And this is in short the clinical correlates of mood stabilizer response. Lithium is better in the euphoric manic